you first think indeed about your spinal CSF venous leak, especially if the patient is SLAC negative. And here you can see in this patient there is a case still that we did back in Toronto. Richard Farr was able to identify the leak right here. You can see the vein going up. And what I would like to show you following treatment, we go back in there, we close the window. This is kind of your goal of your treatment here. And this is before treatment and this is after treatment. And you can see very nicely that all of the findings of the Pearl score are being negative. You see here the pituitary that is enlarged. It is no longer enlarged afterwards. You see that the sinuses are plumb, they are no longer plumb afterwards. You see brain sagging here, and there's no longer any sag here. You see that the 1 milli, like the pontine distance is reduced here. It's no longer reduced there. You see the bilateral subdural hematomas here, and it's gone after the treatment, indicating that clearly this patient has benefited from this treatment. And I think this is what we need to identify in our patients. Another example here, a bilateral hygromas, clear fistula was treated, and this is the patient before treatment and after treatment. You can see that the brain sagging is going away, as well as the flare hypersignal right here on the surface. And then I have a very interesting case here that had a very atypical presentation of intracranial hypotension. So what you can see in this patient is actually that the patient has massive cord swelling, a progressive ascending tetraplegia, and when you are looking at the CSF, what is the interesting portion? This patient has absolutely zero CSF. This is just a massively dilated epidural venous plexus. And there's no CSF here present at all. Patient has a significant leak here, was treated, and now immediately, like I think 1 or 2 days after the treatment, this is his MR. And you see that the edema is already significantly reduced. We now see normal CSF space, and there's less swelling. So what do we believe has happened here in this case? Because of the intracranial hypotension, the patient lost all of his CSF, therefore the cord could no longer pulsate. And what is cord pulsation doing? Well, it's pumping CSF out, the lymphatic system of the cord. And in the moment where you don't have any longer the cord pulsation, there's no longer the possibility of the water in the cord getting and being pushed out. And this is the same type of mechanism that you can see in adhesive arachnoiditis. Following surgery, there are adhesions on the cord, and these prevent the cord from pulsating normally, and then focally you get a cord edema longitudinally, which has been described. And these types of cord edemas can be reversible after you cut like the adhesions in the cord. So this just shows to you that how like diverse the symptomatology of patients with SIH can be. Okay, the goal for this workshop, however, is something different. It's dural arteriovenous fistula. So let's talk about this patient with a 77-year-old female with progressive ataxia. Susceptibility-weighted sequences. What can you deduce from the susceptibility-weighted sequences? 2 things.
So there's numerous prominent vessels over the cerebellum, both cerebral hemispheres. So I'm suspecting a shunt is most likely the germinal fistula.
What does this show you? Because it's dark on SWI.
That it's hemoglobin,
Which means?
that there's venous congestion.
Okay. What is this signal?
Yeah, the right transverse sinus is arterialized.
Perfect.
Yeah.
Okay. So SWI can show both arterialization and venous congestion. You see that there are just way too many vessels. So clearly there's evidence for dural arterial fistula in this patient. So let's have a look at how this fistula is looking like. So we have here scoli on one side, occipital on the other side. Where do you think the fistula is primarily localized to? Difficult to say, but it's just here off the torcular and along the sinus. So our idea was to, obviously in patients with torcular dural arteriovenous fistula, to protect the sinus with a large Copernic balloon here, do a transarterial transvenous approach with a pressure cooker technique, and then go as close as possible to the fistula and start to inject the fistula. You can see that the fistula's flow was so large that we actually even lost half of the coil right here that was then floating around. And still, the patient did not use, obviously, the left side, otherwise he would have not been able to treat it. And you can see that the fistula zone is along the entire left transverse sinus that was not used by the brain. And following the control, you can still see that there's a flow coming here from the posterior meningeal artery towards the torcular proper. But the torcular is now needed. And in these cases, what you will have to do is now to protect the torcular. And what we did was put Copernic all the way into the straight and into the superior central sinus and continue to inject. And this is presumably the biggest and meanest onyx cast that I have in my history of cases. But we were finally able to completely obliterate the shunt here, and the patient did actually fine. And this is the follow-up control of the patient, where you can see that the fistula is completely cured. We have normal filling and no longer the venous congestion that is also seen here. So it just shows that sometimes these types of cases can be extremely difficult, and I think torcular cases are the most difficult to treat because you need to protect the torcular, which may mean that you need to have multiple large Copernic or Mustang balloons in the vessels. Here we have a different case, very similar to the one that was previously shown by one of the students. We have an osteodural shunt at the level of the cavernous sinus with this myriad of small vessels that are going through the bone that are filling the cavernous sinus. What I'm trying to show you here is the significant osteodural component of the shunt. You see all of these vessels here coming off, going through the bone to fill the cavernous sinus. You see that the cavernous sinus is filling from one side to the other side, that it's a widespread fistulous zone, and that we have quite a few of like outflow routes, here both from the left and from the right side. And when we are seeing this, we will have to identify which one are the dangerous ones. And from the reflux perspective, from an endovascular perspective, a transarterial route is contraindicated here because of the potential of reflux into ILT and MHT. When you're looking at the venous phase, what I really like to do is identify all of your dangerous vessels here that are refluxing, because it will be difficult to completely obliterate the shunt if you're just putting coils into the cavernous sinus, and you may reroute your flow into those dangerous veins here. So I think that we have here the basal vein of Rosenthal bilaterally there and there, in the way that the basal vein of Rosenthal is interconnected to the cavernous sinuses via the ankle vein here and here. There's evidence for the IPS, there's evidence for the superior petrosal sinus. maybe even the superior petrosal vein going here to the posterior circulation. We have evidence for the sphenoparietal sinus both on the right and on the left, which will lead to significant venous congestion then here, mainly over the right hemisphere, but also over the left hemisphere in a later phase. And rather than now treating just the fistula, which, as I said, will be difficult given the myriad of vessels that are here, and the danger that even if you're coiling it and then pushing onyx in it, at one point in time the onyx will go back into MHT ILT. I decided to first go into each of these different veins, pilot veins, from the cavernous sinus and close them off one by one. So we are going into the sphenoparietal sinus, we are going into the uncal vein on one side, the uncal vein on the other side, the sphenoparietal sinus on the other side. And then once we have done this, once we have more or less disconnected all of the potentially dangerous reflux routes, can you go back into the cavernous sinus and then do dense coiling of the cavernous sinus, which will then lead to the patient having no longer any cortical venous reflux. There is still some fistulization, but no longer cortical venous reflux. And then we can just wait for the patient, bring the patient back after 3 months and see whether there's still anything left to do. So what I'm trying to show you with this case here is sometimes you don't need to go for a cure, but just to change like a malignant dural arteriovenous fistula into a benign one by removing the cortical venous outflow tracts.
Do you think it's a cavernous dural AVM or is osteodural?
Osteodural.
Why do you say osteodural?
Because of all of these little arteries that go that appear to go through the bone into the cavernous sinus. So this is not, I would believe, your classical dural arteriovenous fistula, but a fistula that is coming through the bone and that is present primarily within the bone.
I think we have to make it clear where the location of the shunt is. And it's not because the feeders are coming through the bone, but if the shunt is in cavernous sinus, I think we should call the cavernous, dural AV shunts. And osteodural, what I understand, osteodural is more of intradiploid space, or what we see more of the condyloid venous shunts of this.
Yes, it is. I think this is underdiagnosed. I think if you do high resolution CT or MRI, you will see incredible vascular network within
the bone. If it's a shunt is within the bone, yes, we call it osteodural. But shunt is really in the cavernous, the dural of the cavernous sinus, I don't know.
So the question is, do you see veins within the sinus? It's the figure thing in the clivus.
Yeah.
I don't see those, but I do see this very widespread network of fine arteries that then go into the entire cavernous sinus, both on the right and on the left side. And this is different from most other dural arteriovenous fistulas, I think, of the cavernous sinus, where you have more of a compartment of the sinus that is being fed by primarily a dural branch, whereas here the feeding arteries are primarily
I agree.
But you are right, the fistulous connection is within the dura and not in the bone.
Yeah.
Which was different from the other case that I showed you.
Yeah, the arterial supply, as you said, is completely different.
The other one, you have shunt is in the bone.
Okay. And so you have some cases.